Okay, so I'm just going to invite our next speaker, who has spoken before, and you all know Sri Ganesh, who obviously is one of the preeminent refractive surgeons on the planet, no question about it. Experience in all levels of refractive surgery, and again, he's going to take you through his own decision process as to how the clinical pathway works at his clinic, and how he decided to choose PRESBYOND for his eyes.
Good afternoon. It's always difficult to speak after Dan, but then I think we'll have him also speaking in my presentation. So this is a presentation on my perspective on the decision pathway that I took for myself and why I chose PRESBYOND. What were the factors that led me to choose this for myself? To start off, of course, I was almost ametropic, maybe slight hyperopic, and I always had 20/10 distant vision, excellent vision, never worn glasses in my life. The difficulty started around 45 years when I had difficulty reading small print, dim light. Then slowly my intermediate vision also got affected by 47. My hyperopia increased, and then I was totally dependent on glasses. I tried multifocal contact lenses, but then they were terrible. I had a lot of glare, the quality of vision was bad, I was not able to tolerate them. So then I thought about getting refractive surgery. Why refractive surgery? What are the factors that influenced me? I was handicapped for near and intermediate vision without glasses. I couldn't see my mobile phone, I couldn't see my laptop, iPad. And the decision was more for functional reasons than cosmetic. My refractive patients were asking me about my glasses. I've been doing refractive surgery for now 17, 18 years. I never wore glasses. Now I wear glasses when I have to see my patients, see the charts, and some of them at the end of the consult say, "Doc, I have one last question," and I know what's coming up. Why are you wearing glasses when you suggest refractive surgery for me? And I also had difficulty doing refractive surgery, as I have to see both through the microscope and the monitor. So I had to wear my progressive glasses, and then when I look up, and it was a pain. I also do a lot of sportive activity, including scuba, snorkeling, and it's very difficult to wear glasses or contact lenses, and you need to look at your dials and oxygen supply, very critical. I had a nice large collection of shades which I couldn't use. So this is also one of the factors. But of course I had my fears and questions. As a high volume surgeon, I do about 4,000, 5,000 cataract surgeries a year, about 2,000 refractive surgeries, and it's my bread and butter. So my vision is very important as a surgeon. Will it reduce my quality of vision? Will my stereopsis get affected? Can I work under the microscope? Will it interfere with my surgical work? Because this is what I do most of the time. What if I don't get an optimal result? Can it be enhanced? And then what type of procedure should I get done? Who will do my procedure? These were all questions. Coming to the clinical decision pathway, let us look at the various options for presbyopia. Which procedure? Now you have so many of them. So let us look at start from the corneal inlays. Of course, you have the camera, which is a pinhole technology, and more than 20,000 procedures done. It looked a little exciting, but then I had a lot of surgeons, colleagues whom I discussed, and then some of them had given up this procedure, and you can have all sorts of problems, from a decentered implant to even corneal melt, serious issues. And anyway, who wants a pinhole? I mean, how many of us use pinhole cameras? I don't think any of us use pinhole cameras, because it works only in bright light, and you have varying light conditions throughout where you want your vision to effectively work. The other inlays, like the FlexiView and the raindrop, of course, no long-term results, small cases done, we don't know what will happen. And you always need a second procedure. It's not only one procedure. You need, for the camera, you need to make the patient myopic by about 0.75 to 1 diopter for it to work well. So there are two procedures. One a LASIK procedure, and then the second is the implant. So why not just do one procedure? Coming to LASIK procedures, because LASIK is proven, you have monovision LASIK or SMILE. But my procedure, I have done a few of monovision LASIK, but patient satisfaction again is not too good. I had to reverse a few of them. I was not too convinced. Like Glenn said, it's only about 65% acceptance. Of course, I've been trying a lot of presbyopic solutions. I even started CK, gave it up because of the regression, then multifocal LASIK with PRESBYOND. But again, with PRESBYOND, what I saw was that patients were not very happy. There was no wow factor. I was not getting back referrals from those patients. You had to handhold them for almost 3 months. There was loss of best corrected vision. And multifocality on the cornea is something, the quality of night vision was not too good. Of course, then we had laser blended vision, and I think Glenn has spoken about how it is done and the basis. It's micro monovision with increased depth of field, and this was something which I've been doing from 2 years, so I had some experience. I'll talk about it. Coming to refractive lens exchange with multifocal IOLs, of course I do a lot of cataract surgery. I've done about 70,000 cataract surgeries and more than 5,000–6,000 multifocals. I've used all of them from Array, Resume, Restore, the trifocals, the Symphony, but then I don't think I'm old enough to have a refractive lens exchange. And I have seen all the complications possible when you do such a big number. It's an intraocular procedure. And coming to the presbyopic phakic IOLs, again, not much of experience. Why I didn't choose an intraocular procedure? What I have seen with intraocular procedures with multifocal lenses is it is good if there is a reduction in vision, if there is cataract. Refractive lens exchange patients, I've done a few of them, including trifocals and the bifocal lenses, but they have issues like quality of vision, night vision, loss of contrast, and even with the trifocals, the reading is not as good. They need more light to read. So that is one of the things. And of course, there are serious risks of intraocular procedures. Though it's very low, maybe about 0.1%, but if you fall within the 0.1%, then I don't want to lose my vision. To endophthalmitis, recurrent uveitis, CME, retinal detachment. You also have moderate risk like PC rupture or PCO, and you have the lower problems like glare and halos. Most patients complain of that, loss of contrast, and you can have refractive inaccuracies for which you, in 20% of cases, you may again have to use a laser to correct it. This was my experience with the PRESBYOND. I had 3 Schwinn machines, 38% of the eyes, 38 eyes, 45% had one or more loss of lines at 15-day follow-up. So this was fairly significant. And 2 eyes had a 2-line drop in distance vision, which persisted even after 6 weeks of follow-up. So this is something which I was not very comfortable. I started this procedure. This is not the new software, it's the older software, but then I discontinued after some time. Then I finally decided on PRESBYOND. Why PRESBYOND? Because I was seeing that it was giving the highest patient satisfaction. These patients were really happy after the procedure. Good functional vision. We checked patients with the SRD, with the progressive, and then after the PRESBYOND, we found that the functional vision was better than glasses. And it has the safety and track record of femto LASIK. It's nothing but LASIK, and millions of procedures have been done. Follow-up data and satisfaction of my staff. I've treated a lot of my staff with PRESBYOND, followed them up for nearly 2 years. They're very happy. I questioned them. I've been doing detailed assessments. It's easily adjustable. You can do an enhancement. It is reversible also, unlike a multifocal cornea. And there are no permanent side effects like glare and halos. Even if you have a little bit of halo, you can correct it with glasses in the non-dominant eye. The other very attractive thing is it closely simulates the natural existing condition in patients. There are many patients with some amount of anisometropia and increased depth of field. My wife has never worn glasses. She has 1.75 in one eye, and she's very happy. Even if she gets glasses done, she never wears it. And this is something which, whatever simulates nature is very successful. Multifocality is not natural. You have good contrast, sensitivity and stereopsis, and I don't have a problem because I can always adjust the ocular in my microscope in my non-dominant eye, and my stereopsis is perfect and I can do my surgery. I can even maintain my blended vision after cataract surgery if I just use a monofocal with micromono vision. This was my pre-op data. I was hyperop 0.75 to 1 diopter, small astigmatism, normal topography. This is again the atlas topography. And this is the planning. I had a little higher spherical abrasion. The Z4 was around 0.6. So we input that. And this is the surgery on 6 months ago.
Superlative eye-inch. Looking straight ahead, and in the middle there, the green flashing light. The green flashing light's going to come nice and close and make it go sharp.
I got my surgery done at a conference with 500 doctors watching this procedure. Next, eyebrows.
Congratulations!
So I was able to read J1 Plus immediately after the procedure. You can watch the full video on YouTube. So that was at a conference, live surgery, I got it done. So this is my post-op data at 3 months. I had 0.25 residue in the right eye with uncorrected 6/3 2010 and N10. Left eye was 1.75 and 6/4.5, that is 2015 and N5. Binocularly, I have 2010, 6/3 and J1 plus. These are my topographies. The intermediate vision, monocularly, left eye is N5 at 60 centimeters and N8 at 80 centimeters. Binocularly, N5 at 60 centimeters, N6 at 80 centimeters. Stereopsis is excellent, 60 arc seconds without correction, and with correction it's 20 arc seconds. So there's no loss of stereopsis, and I have an excellent range of vision. At near point is about 20 centimeters. I can even see J1. Far point, I can up to my arm's reach, so I can see the speedometer in my car very clearly, and the computer. This is the post-op topography. You can see that there's more steepening in the left eye. That's after the procedure with my surgeon. That was pre-op, and then he was just showing the ad of Zeiss, and post-op I look much younger without my glasses. 14 hours after the procedure, I did live surgery. I performed live surgery, cataract surgery on a small pupil, difficult case in the conference. Were there any side effects? Mild dry eye, especially after a long surgical list. If I do 30-40 cases, then I have a little dry eye. Halos at night in the left eye. First 3 months, it was correctable wearing glasses, but now after 3 months, the halos have just disappeared, and I'm very happy with my vision and would strongly recommend this to all my patients and my colleagues. It has its indirect benefits. Like you see, after my surgery, my volumes of PRESBYOND just shot up. Patients who came in did not take any chair time. Once you say that I've got it done myself, they say, okay doc, I can get it done. If you have confidence in the procedure, then it's good enough for me. Even the cost benefit, if you look at phaco with trifocal lenses, you have a 27% profitability. With flax with trifocal IOLs or the Symphony, you have 25% profitability. With femto PRESBYOND, it's cheaper for the patient, and you have a 71% profitability. So even financially, it makes business sense. And this is my comparative practice patterns with PRESBYOND, and you can see year on year, my volume of PRESBYOND has increased when compared to both multifocal and monovision correction. Thank you very much for your attention.